Okay, hello everyone. Welcome to our session this evening, partnered with Quesmed, run by Study Hub. Dr Hannah Cullumbine is very kindly offered to run this session for us on SBAs in renal physiology. She's an anaesthetics doctor, so I think she's going to, have loads of helpful stuff for us to learn and upcoming exams. I know a lot of universities have that at the moment, and also just for general knowledge as well. As usual, any questions at all, please post them in the chat. On any technical difficulties, I'll try and sort them out as they arise. And there'll be questions later on in the presentation as well. But yeah, I'll hand it over to you, Hannah. Thank you so much for volunteering to run this.
So thank you everyone for coming. Some of you might have attended some of my previous physiology lectures, so I've done a respiratory and a cardiovascular physiology session before, so hopefully this one is useful for you. I know that renal physiology was always something for me that was a bit of an abstract concept, and having done lots of exams and lots of having to relearn it and relearn it again, hopefully I'll be able to come up with some useful tips and tricks to help remember things. So without further ado, so our objectives for this session today are to revise the key concepts of renal physiology, including the functions of the kidney, glomerular filtration, reabsorption and secretion along the nephron, and water balance. Okay, so we're going to begin with question 1. Which of the following are included in the functions of the kidney? Is it A, vitamin D activation, urea synthesis and acid-base balance? Is it B, creatinine release, removal of toxins and control of blood pressure? Is it C, breakdown of red blood cells, water balance and acid-base balance? D, electrolyte balance, vitamin D activation and erythropoietin release? Or E, water balance, creatinine release and acid-base balance? I'll just give you 30 seconds or so to answer that one. All right. Has everyone had a chance to vote? So is that worked there? Oh, here we go. Okay, so we've said 75% of us have said D, so that's electrolyte balance, vitamin D activation and erythropoietin release. And the correct answer is D. So going through the wrong answers, so the kidney does get rid of urea, but it's not involved in the synthesis of urea, that's the liver. The muscles are the main perpetrators for releasing creatinine, but again, that's filtered by the kidneys. Breakdown of red blood cells happens within the spleen, and then in terms of answer E, so creatinine release, again, we've already said happens in the muscles mainly. Okay, so a way that I got taught to remember the functions of the kidneys, just so that you don't miss out on any of them, because we do know that they filter out toxins, get rid of water, but they have a few other functions. So a nice way of remembering it is our wet bed. So they control acid-base balance, water balance, electrolyte balance, they remove the toxins, and then B is they are involved in the control of blood pressure, which we'll come on to. E, erythropoietin release, so that's stimulated by low hemoglobin levels, and D, the activation of vitamin D. Okay. Question 2. Which of the following is the most accurate marker for measuring glomerular filtration rate? So it's the most accurate. Is it A, creatinine, B, inulin, C, deuterium, D, para-aminohippuric acid, or is it E, urea? Okay, and so we've got about a 50-50 mix of creatinine and inulin, with a few people also saying urea. Okay, so going through each of the options, so creatinine is, okay, so first of all, the correct answer is inulin. So we may have thought it was creatinine because creatinine is often the marker that we use in practice as a marker for glomerular filtration rate. And that's because it's much easier than inulin to measure because it's released from muscles at a constant rate, okay? Because of that, we don't need any special infusions or anything like that to be running in order to measure the creatinine levels because it's already being released by the body. However, creatinine is actively secreted by the tubules in the kidney, so we actually get a slight overestimation of glomerular filtration rate with creatinine. The answer, inulin. So inulin is a structure found in plants. It's not something that we produce ourselves, so it has to be given as a constant infusion, and inulin is the ideal marker. So we'll move on to that in a second. Deuterium, that is heavy water. So that's where the one of the atoms in water is an isotope, and so it's a heavier version of water, and that is used to measure total body water. Para-aminohippuric acid is completely removed from the blood supply via the nephron, and therefore that's a marker of renal plasma flow. And then urea doesn't really have very much to do with measuring glomerular filtration rate. So I've drawn a little glomerulus here. It's a little bit wobbly, so just bear with it. So we've got our glomerulus here, we've got an afferent arteriole at the start and an efferent arteriole at the end. And we've got the Bowman's capsule. So what happens, because we've got an arteriole at both sides of the capillary bed, this is a much higher pressure system in terms of the capillary bed than most other capillary beds in the body. It also means that because arterioles, as we've discussed before, are quite muscular structures in comparison to the venous drainage system, it means that you can constrict these arterioles in order to increase the pressure and give a higher filtration rate when needed. This filtrate moves across into the Bowman's capsule, and the Bowman's capsule is what collects that filtrate and allows it to move along the nephron. Okay, so the kidneys get around 20% of our cardiac output, which is huge considering how tiny these structures are. We get about 1.2 litres per minute of blood going to the kidneys. So again, that's allowing really high pressures in order to allow this filtration. The renal plasma flow is about 600 to 720 mils per minute. And so that's with a normal hematocrit of about 40%. And then the glomerular filtration rate, so what actually moves from here into the Bowman's capsule, is about 120 to 125 mils per minute. Okay, the ideal marker for measuring glomerular filtration rate is a marker that's freely filtered, so that it can freely pass from here to here, where the concentrations between the two remain the same. But we don't want it to be reabsorbed, secreted, or metabolized. So along the nephron, we don't want more of it to get added into the filtrate, and we don't want more of it to get reabsorbed back into the bloodstream. And we don't want it to be metabolized between getting from the blood to the nephron. Okay, so with this in mind, when you have the ideal marker, what you want is you want the filtration rates to be equal to the excretion rates. So the rate of filtration would be the filtration flow times by the concentration of that marker in the filtrate. And the excretion rate would be the urine flow times by the concentration in the urine. So as we've said, so inulin is freely filtered, not secreted, not absorbed, or not metabolized, which makes it an ideal marker or the perfect marker. However, because it's quite expensive to run continuous infusions and very time consuming, it's really something that's only generally used in research. Creatinine, which is much easier for us to measure and still gives us a fairly accurate estimated glomerular filtration rate, is freely filtered, it's not absorbed, it's not metabolized, but a small amount of it, as I said, is secreted. So because it's secreted into the nephron, it seems like more of it is getting filtered away. Para-aminohippuric acid is secreted in full, and so as we said, it's used to measure renal plasma flow. Deuterium is freely crosses the nephron with water, and that's used to measure total body water. So once we've injected it, given it time to equilibrate, we can then measure it, and we know from the concentration what the total body water is. And then urea is reabsorbed. It's not used as a marker for any of these kinds of measurements, but we do look at it when we're looking at kidney injuries and things like that. Okay. Next question. So question 3. Which part of the nephron receives the least blood flow out of the following? Is it A, the proximal convoluted tubule, B, the Bowman's capsule, C, the distal convoluted tubule, D, the glomerulus, or E, the loop of Henle? We'll give you another 20-30 seconds to answer that one. Okay, so, oh, we've got a mixture here. There's no clear consensus. So the correct answer is the loop of Henle. Okay. So here's a wonderful nephron that I've drawn earlier. So we've got here, again, we've got our glomerulus, Bowman's capsule, we've got our proximal convoluted tubule here, our loop of Henle, the distal convoluted tubule, and the collecting ducts. So really, this is stretched out slightly because of the shape of these slides. The loop of Henle would actually be much longer, in these two bits would probably be closer together, but just for illustration purposes, this is how this one looks. So the blood flow to the nephron, so the kidney is divided into an outer cortex and an inner medulla. And the majority of the nephron is found in this outer cortex. Around 15% of nephrons have their loop of Henle within the medulla, so that goes down right into the middle part of the kidney, okay? And the collecting ducts of all nephrons pass through the medulla. The blood flow to the medulla is about 1/5 of that of the cortex, so most of the blood flow is in this outer part, and then the inner part where we have some of our loop of Henles and some of the collecting ducts is where the blood flow is the least. And for that reason, because we've got those loops of Henle and the collecting ducts in this area of lower blood flow, these are the parts that are the most vulnerable to ischemic injury if we have low blood pressures. Okay. Moving on. Question 4. At what blood glucose level does glucose reabsorption start to become saturated? Is it A, 5 millimoles per litre, B, 8 millimoles per litre, C, 11 millimoles per litre, D, 15 millimoles per litre, or E, 20 millimoles per litre? Okay. So we've got another slight mix of answers. So we're going between B, C, or D. So they're kind of our middle ones. So the correct answer is C, 11 millimoles per litre. Okay. I'm sure that in different texts it might be kind of one above, one below, so don't worry too much. So the part of the nephron that we're looking at for glucose reabsorption is the proximal convoluted tubule. That's because in the proximal convoluted tubule, that reabsorbs 99% of the glucose that we filter, 99% of the bicarbonate that we filter, 70% of the sodium that we filter, and wherever sodium goes, water also follows. So we also reabsorb around 70% of the water that we filter there. Okay, glucose reabsorption is via the sodium glucose symporter. So what symporter means is that the glucose and the sodium are both going together through the carrier protein, but in the same direction. And because this is a protein, a carrier protein, in the same way as enzymes can become saturated, so can these transporters. And they have a transport maximum of around 1.5 to 2 millimoles per minute. Some nephrons will have a higher transport maximum and some will have a slightly lower transport maximum, okay? At a plasma glucose of around 5, so normal, and a glomerular filtration rate of around 120, we'd have a glucose reabsorption, or the transport speed, so the movement of glucose back via this protein would be 0.6 millimoles per minute, and that's well below these Tmax values, okay? Now, like I say, with glucose reabsorption, there are some nephrons which will reabsorb glucose, which will stop reabsorbing glucose or reach their Tmax sooner than others. And in those, that's why this part of the graph here is a slight curve, is because some nephrons have reached their Tmax, whereas others still haven't yet, okay? What this graph shows is, so along this axis, we've got the rate of glucose filtration, reabsorption, and excretion. And then along this side, we've got the plasma glucose level. So as the plasma glucose level rises, the filtration increases with the plasma glucose level. So this red dotted line is the filtration. The green line here is the reabsorption. So what happens is, to begin with, the more glucose that gets excreted, the more gets reabsorbed, and that they just follow each other. So the same amount gets reabsorbed as what gets excreted. Once you reach this threshold value here, the nephrons start to become saturated and they can't reabsorb any more glucose. So this line starts to plateau. So we've got this slight, like we said, a slight curve because some reach their Tmax sooner than others. And then at that point, it doesn't matter how much more glucose is being filtered, we've reached the maximum amount of glucose that can be reabsorbed. And then at that point, we start to get glucose excretion, and that's what this purple line demonstrates. And so this threshold, that should be somewhere around 11 millimoles per litre. Question 5. What is the function of the loop of Henle? Is it A, to reabsorb the majority of sodium from the filtrate. B, fine-tuning of sodium and water balance. C, to create a large osmotic gradient to facilitate water reabsorption from the collecting duct. Is it D, bicarbonate reabsorption, or is it E, prostaglandin E2 release? Okay, so the majority, 58%, are saying C. We've got some saying fine-tuning sodium and water balance. Okay, so the correct answer is C. So the loop of Henle. So here illustrates the loop of Henle. So what we've got is we've got a thin descending limb and a thick ascending limb. Okay. The thin descending limb is permeable to water, so water can freely move between the nephron and into the bloodstream, but it's completely impermeable to electrolytes. And then moving across to the thick ascending limb, we've got the thick ascending limb is completely impermeable to water, so water can't move from the nephron into the bloodstream at this area, but there is a active transport, a pump, sodium, potassium, 2-chloride pump, which pumps out those ions in that order. So because we've got a positively charged sodium and a positively charged potassium, the 2 chlorides accompany that so that we get a net neutral pumping effect, and they move out. So the way that I've remembered this is because this limb here, we're requiring proteins in order to do active transport, and therefore that's probably going to have to be a bit thicker in order to be able to do all of that, because you're going to need energy and you need proteins and carrier proteins and all of that kind of stuff. Whereas this side here is just permeable to water, and the water can just move across through the channels. Okay, that's the way that I remembered it anyway. So here we go. So the loop of Henle works via a countercurrent system. So what that means is the blood vessels that surround the loop of Henle is called the vasorector, and they move all around the limb so that there's a really good surface area for stuff to move from the nephron into the bloodstream. We have the filtrate moves from the thin ascending limb up the thick ascending limb. So you've got your proximal convoluted tubule on this side and your distal convoluted tubule on this side. Whereas the vasorector moves in the opposite direction. So you've got blood flowing from the side of the distal convoluted tubule to the side of the proximal convoluted tubule. And this is a dynamic system. So as this moves on towards the proximal convoluted tubule, this moves away. And what that is allowed to do, because we're constantly moving the blood and constantly moving the filtrate around, it allows as we get deeper into the either to the deep area of the cortex or deep into the medulla, it creates this really, really concentrated solution in the space around the vessels and the nephron. So that's the interstitial space. That becomes really, really concentrated solution. So as we're moving down the down the thin descending limb, we're getting more and more concentrated as water's moving out and water's moving out and water's moving out. And because the surrounding area is becoming more concentrated, water is still allowed to move out all the way down that thin descending limb. As we start moving up, so as we start moving up the thick ascending limb, the electrolytes keep on being moved out and out and out, and that reduces the number or the amount of particles, so that makes this solution in here in the tubule very low concentration. So the concentration within this area of the thick ascending limb just before it becomes the distal convoluted tubule is less concentrated than the filtrate that we're started with. Okay. Now, in doing this, in creating this really, really concentrated environment down here, this aids water reabsorption in the collecting duct. So as we said before, the collecting ducts all pass through the medulla. And so if we've got a really, really concentrated medulla, which is caused by this countercurrent system, then more water is going to be wanting to move from an area of low concentration to an area of high concentration, as with osmosis. Okay, so if we go back to our GCSEs and A levels of osmosis, so the water wants to move from an area of low concentration to an area of high concentration. Hopefully that made sense. We can always come back to it at the end if anyone has any questions, okay? Question 6. Which hormone stimulates V2 receptors to release aquaporins in the collecting duct? Is it A, renin, B, aldosterone, C, angiotensin II, D, antidiuretic hormone, or E, brain natriuretic peptide? Okay, so the vast majority of us have said D, antidiuretic hormone, and that is indeed the correct answer. Okay, so for anyone that came to my cardiovascular talk, you might have seen something similar to this slide before. So the vasopressin or antidiuretic hormone is released from the pituitary, and it's released in response to angiotensin II, sympathetic stimulation, hyperosmolarity, so that's when we have a low amount of water or the blood is really, really concentrated, hypovolemia, so we've got a low volume of blood, and hypotension, so low blood pressure. And vasopressin stimulates two different types of receptors. So we've got our V1 receptors, which aren't really anything to do with the kidneys, and we've got our V2 receptors. So our V2 receptors, they increase water retention from the kidney, and that is by releasing aquaporins. So the V2 receptors are around the collecting duct. The vasopressin will bind to the V2 receptors, and this will allow aquaporins to be released and essentially bond with the membrane of the collecting duct. And because of that, and because the collecting duct is moving through that really concentrated environment, water moves through those aquaporin channels from an area of low concentration to an area of high concentration. And that is how we retain more water, therefore increasing our circulating volume and increasing our arterial blood pressure. Okay, so this is the area in which they act. So the aquaporins would be moving along these channels, and as the collecting duct starts to progress down into the medulla in the area of high concentration, the water, more and more water will move out, making the urine more and more concentrated. Okay. Question 7. What does aldosterone cause? Is it A, sodium reabsorption and potassium reabsorption? Is it B, sodium reabsorption and potassium secretion? Is it C, sodium reabsorption and glucose reabsorption? Is it D, potassium reabsorption, sodium secretion? Or is it E, sodium secretion and potassium secretion? Okay, so we've got 80% of you guys saying B, so sodium reabsorption and potassium secretion. Okay. And that's the correct answer. So aldosterone works in the distal convoluted tubule, so that's this part of the nephron. You can tell by now that I'm really proud of my nephron drawing because it's come up a lot in this. Okay, so in the distal convoluted tubule, we have 2 different types of cells. So the cells in which aldosterone acts, they have a potassium and sodium channel. So aldosterone encourages these channels to be released. And therefore, in these cells, the potassium is moved from the cell into the tubule, so that is secreted into the filtrate or secreted into the urine, and sodium is reabsorbed from the urine. And then at the cell, this side of the cell membrane, so this is kind of on the base of all cells along the nephron, we've got the sodium and potassium pump. So essentially sodium is being pumped out into the interstitium, and then it moves straight across from the interstitium into the capillary, and water can follow, whereas potassium is being moved away and into the tubule. Okay. Question 8. Which part of the kidney is renin released from? Is it A, macular denser cells in the juxtaglomerular apparatus? Is it B, intercalated cells in the distal convoluted tubule? Is it C, granular cells in the juxtaglomerular apparatus? Is it D, principal cells in the distal convoluted tubule? Or is it E, tubular cells in the loop of Henle? Okay, so we've got a lot of us are thinking A, macular denser cells, and C, granular cells in the juxta. So we're in agreement that it's the juxtaglomerular apparatus, but we're just not sure which part. So the correct answer is granular cells in the juxtaglomerular apparatus. Okay. So here we have the renin-angiotensin-aldosterone system again. Essentially, when we have a reduction in filtration, therefore a reduced amount, so our glomerular filtration is reduced, and therefore there's a reduced amount of filtrate in the tubules. We have macular denser cells, which are in the juxtaglomerular apparatus. They're found at the border between the distal convoluted tubule and the arterioles. And these are osmoreceptors, so these can detect fluid within the tubule. What happens then is when the macular denser cells sense that we have a reduced amount of filtrate, they transmit a signal to the glomerulus, and the vascular smooth muscle in the afferent arteriole adjusts the glomerular filtration rate. What also happens is the macular denser cells, they stimulate the cells, so the granular cells in the juxtaglomerular apparatus, to release renin. And then that starts the whole cascade of the renin, angiotensin, and aldosterone system. Okay. So, as we know, renin is released from the kidneys. What happens then is it cleaves angiotensinogen into angiotensin 1. Then angiotensin 1 goes to the lungs, where it is transformed into angiotensin 2. And then angiotensin 2 then acts in multiple ways to bring blood pressure up. And in bringing blood pressure up, it causes a higher glomerular filtration rate, because we have more, if we have a higher blood pressure, a higher cardiac output, then we're getting more blood to the kidneys. So it does that by increasing aldosterone, which we've already seen causes sodium and water retention in the kidneys, and we've seen how that happens. It causes systemic vasoconstriction, and it also causes vasopressin release, which again, we've kind of touched upon of how that works in terms of increasing circulating volume. Question 9. Which of the following hormones causes efferent arteriole constriction? Is it A, angiotensin 2? Is it B, renin? C, vasopressin? D, adenosine? Or E, prostaglandin E2? Okay, so angiotensin 2, adenosine, prostaglandin E2 are our main ones. So the correct answer, we have angiotensin 2. Okay, so this question concerns essentially blood flow to the glomerulus. So the kidneys, this should say renal. Never mind. So this here should say renal. So the kidneys, like many organs in the body, like the brain, like the heart, undergo something called autoregulation. And what that means is over a range of different blood pressures, the kidneys will still function, and so will still maintain glomerular filtration. And that occurs over a range of about 80 to 160 millimeters of mercury. Okay, so what happens when we have reduced renal blood flow? So a reduced renal blood flow will mean that glomerular filtration would go down because we're having less flow to the kidneys. So what happens is, to try and maintain that glomerular filtration, we have two different hormones. So prostaglandin E2 is released following a fall in filtration rate. What that does is that dilates the afferent arteriole to help maintain renal blood flow, because if we're dilating that arteriole, then it's easier for blood to come in through that arteriole, and therefore more blood is getting there, and therefore more can be filtered. On the other side of things, angiotensin 2, which is released via that cascade of the renin-angiotensin system, is released, and that is generally in a response to reduced renal blood flow. What happens there is that constricts the efferent arteriole, and that maintains glomerular pressure by causing a back pressure. So while this arteriole here is more dilated and more blood is going to that glomerulus, it's then receiving a back pressure here. More blood is being pushed backwards, and therefore more is able to be filtered, because both of these mechanisms, where you're allowing loads of blood in but then stopping it from leaving, that then creates this high pressure within the glomerulus, and therefore we maintain glomerular filtration. What's important about these, and for those of you in higher years who might be starting to think about pharmacology and disease management, so prostaglandin E2 is a prostaglandin, and we know that NSAIDs, so our non-steroidal anti-inflammatory drugs such as ibuprofen, they inhibit the formation of prostaglandins. That's part of their mechanism of action. And therefore, if we give NSAIDs, then prostaglandin E2 release is reduced, and therefore we can't as well do this dilation of the afferent arteriole when we have a reduced renal blood flow. So it's only when renal blood flow is reduced that this becomes a problem. In contrast to that, angiotensin 2 conversion is inhibited by ACE inhibitors. So that's things like ramipril. So if we give a patient with a low blood pressure or reduced renal blood flow, both an NSAID, so something like ibuprofen, and also an ACE inhibitor like ramipril, we're damaging both of these mechanisms, which help to maintain glomerular filtration rate and renal blood flow, and therefore we can cause real damage to the kidney. So it's something that we do need to be quite careful of and keep in mind of these two mechanisms of action of these two different drugs and the way in which they affect the kidney, particularly when renal blood flow is reduced. In normal renal blood flow, this is most of the time, this is generally under the control of adenosine. So adenosine is released in normal hydrated states from the macula densa, and it constricts the afferent arteriole. By constricting the afferent arteriole, less blood is able to get through into the glomerulus, and therefore that reduces glomerular filtration rate. And adenosine is inhibited by the release of renin. So when someone's hypotensive and renin is being released, adenosine is then inhibited. So they work as a negative feedback kind of mechanism. In fluid overloaded states, so we've spoken about this a little bit again in our cardiac physiology. So when the heart is being overstretched, BNP and ANP are released from the heart due to stretch. And we want to get rid of as much of that fluid as possible. And the main way that we get rid of fluid is by peeing it out. So when we've got these really fluid overload states and really overstretched hearts, what we want to do is we want to, again, dilate this afferent arteriole and constrict this efferent arteriole to, again, increase our glomerular filtration rate, and therefore hopefully increase the amount of urine that is produced, because we've got more filtrate being produced. Okay, we're on to our last question. It's been quite a whistle-stop tour today, so we'll have time for questions at the end. So what is the acceptable urine output in an adult? Is it A, greater than 0.1 mils per kilogram per hour? Is it B, greater than 0.05 mils per kilogram per hour? Is it C, greater than 0.5 mils per kilogram per hour? Is it D, greater than 1 mil per kilogram per hour? Or is it E, greater than 2 mils per kilogram per hour? Okay, so the majority of us are saying C, and that is the correct answer, so 0.5 mils per kilogram per hour. Okay, so in a 70 kilogram adult, so we're just going back to these numbers again, just to try and understand the magnitude of what the kidneys do. So our renal blood flow is about 1.2 litres per minute, and that's 20% of our cardiac output. And of that, the plasma flow is about 600 to 720 mils per minute. Our glomerular filtration rate is 120 to 125 mils per minute. And then the acceptable urine output for an adult. So obviously, if someone's drank loads of water, they might pee loads more. But what we would consider to be kind of a pathological state would be the less than 0.5 mils per kilogram per hour, and that's about 35 mils per hour. Okay, so that's a huge difference. So, you know, we're talking about over 6,000 mils per hour of glomerular filtration rate versus around 35 mils per hour of urine output. So the vast majority of that is reabsorbed back via these nephrons. Okay. So that is our final question. So in summary, this is a nice little summary slide that I've made just to kind of help us to remember what each part of the nephron does. So again, we've got our glomerulus with our afferent and efferent arteriole, and then a Bowman's capsule. We've got our proximal convoluted tubule, where the majority of reabsorption takes place. So that's our sodium, our potassium, following up the sodium, the water, and also glucose reabsorption, as well as the majority of bicarbonate reabsorption. We've got our loop of Henle that creates a hyperosmolar environment. So that's an area of really high concentration, so that when the collecting ducts come down through the medulla, a lot of the water is able to move across by osmosis. We've got our distal convoluted tubule. So that's where the fine tuning takes place, and that decides our final urine sodium levels and our final urine acidity levels. And then we've got our collecting duct. So that's the final urine water amount. And that's determined by the aquaporins. Okay. I know I've not been able to cover every single part of the kidney during this talk, but we've kind of talked about the main features of what the kidney does. So the acid-base balance, water balance, electrolyte balance, removal of toxins, control of blood pressure. We've touched on erythropoietin release and touched on the activation of vitamin D. So thank you everyone for listening. If anyone has any questions, please type them in. We can go back to any of the slides if I haven't explained something in a way that you have been able to understand. So just, okay, so.
Thanks so much, Hannah. I think we've got some questions in the chat and then also in the Q&A bit.
Yeah.
If you can see those.
Can we repeat the answer to question 3? We certainly can. So question 3. So the question 3, the answer, the part of the nephron which receives the least blood flow is the loop of Henle. And the reason for that is because around 15% of our loop of Henles go down into the inner medulla, and only about a fifth of the blood flow to the medulla, only about a fifth of the blood flow goes to the medulla as that of the cortex. Why is an ACE inhibitor given for CKD patients? I think that's a really good question. I am not a renal physician by any means, and I don't want to give an answer that could potentially confuse things. So I think the best thing to do would be to look that one up, I'm afraid. So sorry, I don't want to, I could guess at it, but I also just don't think that would be useful for anyone. So can I re-explain the filtration reabsorption graph? I certainly can. So here we go. So what we're talking about here is we're talking about glucose reabsorption. So we've got 3 lines here. The red line, the red dotted line, is the glucose that's filtered from the glomerulus, which goes into which is filtered, yes, from the glomerulus into the Bowman's capsule. Our green line is the glucose that is reabsorbed from the proximal convoluted tubule back into the bloodstream. And our purple line is the amount of glucose, or the concentration of glucose, which is left in the urine after reabsorption takes place. So that's what we end up excreting in our urine. So what happens initially is, as plasma glucose levels increase, more glucose gets filtered, because the filtrate ends up having the same concentration of things like sodium and glucose, potassium, etc., as the blood. And that's because the fluid moves across, but there's no shifts between the actual molecular composition of the filtered molecule. So as long as the molecule is small enough to fit, it will move across in the same concentration. What happens in the proximal convoluted tubule is we have our sodium reuptake proteins, and that's a sodium and glucose symporter. And glucose gets transported back from the proximal convoluted tubule to the bloodstream via this symporter. So initially, all of the glucose that gets filtered gets reabsorbed into the bloodstream from the proximal convoluted tubule. Okay, once we get to about this point here, all of the reuptake of glucose starts to become saturated. So the maximum transport ability of those proteins is reached, and therefore they cannot, even though there's more glucose around, they cannot transport more glucose back into the bloodstream. And therefore, because despite the fact that we're at the maximum glucose reabsorption, more and more glucose is getting filtered, that glucose that's being filtered but not being reabsorbed is then being excreted into the urine. So that's what that graph essentially means, is as soon as we've reached that maximum, which is somewhere around 11 millimoles, those nephrons start to become saturated, or the pathways start to become saturated, and then glucose starts to appear in the urine, and that's essentially what happens in diabetes. How similar are these questions to medical school written exams? It's been quite a while since I've done medical school written exams, to be honest. I wouldn't, it's really difficult, and I think that it will depend on your university syllabus. Obviously, the best questions that you can go over would be any that are actually available from the university on mock examinations, or any questions that they release. They will be the most similar to your examination questions. But definitely the more MCQs that you can do, the better, because it's just constantly keeping you engaged. So while I can't guarantee that they will be definitely similar to the examinations, these are just kind of the things that I think are important about renal physiology, the things that are easy to write, or relatively easy to ask questions about, and things that I think potentially could come up. Can you please explain a bit about how and why we use urine creatinine or protein creatinine ratio and what it shows? I really struggle to get my head around it. Urine creatinine or protein creatinine ratio. So this is something that it generally gets used in general practice to monitor people's diabetes control. And essentially the reason that creatinine is looked at is because creatinine is a really, the protein creatinine ratio is used is because as soon as the kidneys start to become damaged and small little bits of protein start to be allowed through, do you know what? I thought I had my head around it, and I'm not sure that I do. It's kind of beyond the scope of our physiology lecture. So I think potentially if you've got any GP placements or GP tutors to explain that to you, that would probably be more useful than me trying to butcher an explanation, I'm afraid. So sorry. That's more kind of getting into our pathology and pathophysiology as opposed to just a physiology lecture. Does anyone have any more questions at all?
I don't see any more in the chat.
Stunned silence. Okay, well, thank you everyone for listening. I really hope that was useful. Do I mind going back to question 1? Of course I can. So question 1 was the functions of the kidney question. So is it so we've said the functions of the kidney. So sorry, I missed the answer about ACE inhibitors for CKD patients. So I think that a question about ACE inhibitors for CKD patients, I think that perhaps goes beyond my experience in clinical experience, as I don't really deal with the management of CKD patients in my day-to-day work, and I don't want to give an answer that could be incorrect. So I think it would be better to just look that answer up yourself rather than me trying to explain it, because I don't, as an anaesthetist, we generally deal with physiology and kind of acute illness as opposed to long-term management of patients. So for that question, I think that would be useful to talk to them. Any other questions? Counter current multiplier. Not sure what the question is. Where can we access the slides? So I don't know if I don't know how it works if Quesmed do end up leaving a database of them somewhere. I know that they do get recorded and put on the Quesmed YouTube channel for people to be able to re-watch the presentations, but I don't know if the slides themselves become available. I'm not sure what the question countercurrent multiplier is asking. Can you be a bit more specific if you have a question about that? Can I explain the countercurrent, please? Okay, so for that, we're going back to our loop of Henle, which we have here. So the countercurrent. So what we have is here, from the proximal convoluted tubule, we get our filtrate moving down into the thin descending limb, and then it moves up into the thick ascending limb to the distal convoluted tubule over there. In the opposite direction, we have the vasorecta, which are the blood vessels surrounding the loop of Henle, and they move in the opposite direction. As this arrow would move to this arrow here next to this one would end up moving to that one. So it's a dynamic system, and these sides are both constantly moving, because otherwise, if these weren't moving, then the system would grind to a halt. We'd get a maximum kind of transport of ions and water within the system, and nothing would change anymore. So by keeping things moving, we're able to constantly move. So for example, here, we've got an area where we've got the lowest concentration. So the concentration within the blood here and the concentration within the filtrate here are very low. And we have ions moving out from here into here. As we get further and further down, the concentrations keep on getting higher and higher. It works really well in this area here where there's water, because we're having water moving out. So again, at the top, the concentration is really low. So water starts to move out from the tubule into the vasorecta. That then gets moved away, and the area, so the bit of filtrate which becomes more concentrated because the water's moved out, moves down a bit, and the area which becomes weaker because the water's moved into it, that moves away. It's replaced by something that's more concentrated, and therefore, because the area that's more concentrated moves next to this bit of filtrate which became more concentrated because water moved out of it, is next to another area which is more concentrated than the tubule, and so then water moves out of it. Then we move, that bit moves away, and we move that bit moves down, and so we're constantly moving. So in the thin descending limb, we're constantly moving our more concentrated filtrates to areas of higher concentration, and then for water, it keeps on being able to move out and move out and move out and move out. And we're constantly getting rid of the weaker concentrations and moving something of a higher concentration next to the filtrate, so that more and more water can move out. As we're coming up here, so the ions, and so the ions are more concentrated here and they're moved out, then that moves, then the area that's weaker because the ions have moved out and the water can't move, moves up to an area of lower concentration. And because the concentration around there is lower, it means that the ions can move out because we're, again, have a concentration gradient. And that keeps on happening again as we move up and up and up. So the reason the countercurrent system works is because it's a dynamic system. And so every time we reach equilibrium, those things move away from each other and we get another concentration gradient forming, and that just keeps on going and keeps on going So if it was static, or if these two things will move, so if this system was static, or if both areas were moving in the same direction as each other, we would reach an equilibrium and transport would cease. But because they're moving against each other, we're able to get a constant movement of ions in the thick ascending limb and water in the thin descending limb. I hope that makes sense. Any other questions? Oh, thank you very much for that comment. That's really nice. So we should have some feedback. So if everyone can fill out the feedback, that would be really helpful to me and to Quesmed. If there's no more questions.
I think that might be all.
Lovely.
Thanks so much, Hannah. That was really, really useful for me as well. So yeah, if everyone can fill out the feedback form, that would be really, really useful for Hannah and Quesmed and Study Hub too. So yeah, thank you all for coming, and hopefully we'll see you again, Hannah, for another session at some point.
Lovely. Thank you very much.